Hello, hello. Well, today I am sharing with you just a short lecture on a couple key slides related to an introduction to healthcare quality and performance improvement. I pull from a variety of resources, a lot of different texts that I use. And so you'll notice that some of the concepts that I cover in our quality improvement courses really, and on all the health services administration courses, really build upon one another. So I may refer to a tool or an approach that you haven't heard before, or it may seem like, oh, we've already talked about this before, but with a new example. And so I just want to say that's intentional. I also take a very applied approach to these courses. So you'll notice that a lot of the slides we talk through, I'll be adding specific examples. So starting out, anytime we talk about healthcare quality, it's really important that we have a leadership style that starts from a place of shared responsibility, meaning that it doesn't matter if you're a leader in a healthcare quality improvement department, like a director of quality and risk management, or a manager of patient experience, or if you're a nurse manager on the floor, if you're a customer service representative, if you're a CEO. We all own and are responsible for quality. We're all responsible for, at the end, a patient feeling safe, trusting us with their care. And so it's really important that we realize that it's not just the clinical and technical professionals who perform a service or the management that leads, but this shared feeling of joint accountability. Because if all of us feel responsible and engaged, if one person has a bad day, if one process isn't performing optimally, we have a whole team rallied around supporting and changing that, right? So it's not one person, it's not one role. And even if you don't see yourself working in healthcare quality, specifically in the future, your job is still to do a good job, right? So you're still invested in that experience overall. So, why do we focus on managing systems when we talk about healthcare quality? Why is it all about systems thinking and systems improvement? Well, even if we individually have good intentions, even if we individually have clinical or technical skill, if we don't have a system constructed with the right policies and procedures, the right management, the right oversight, it's hard to provide great care consistently. And so we have to build a system that sets us up for success, realizing that good medical care is delivered best when it's expertly managed, when someone is responsible for each component and when as much of it is automated towards success as possible. So I keep using this word quality. What does that word even mean? Quality. So what used to be referred to as the Institute of Medicine back in 1990 and their various reports, such as To Err is Human, uh, the original definition back in, and I say original, but back in 1990, is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So that's a dual definition there. We have the idea that we are delivering effective services. So not just focusing on a process goal, or even an initial outcome level goal, but long-term impact. Are we achieving the ultimate goals of the health of population? So both the individual patient's outcome that they're hoping to achieve, but then furthering population health as a whole. Then we also have whether or not this is current professional knowledge. Are we performing a surgery in a way we would perform it 8 years ago? Right? I remember being a part of discussions, I don't know, this was 10, 15 years ago with cardiothoracic surgeons regarding, coronary artery bypass graft cabbage procedures. And were they performing that procedure according to current knowledge? Not 3, 4 years ago, but as we're looking at the research that changes over time, surgical techniques, right? Recovery, nursing practice, all those things change and improve hopefully over time. Are we doing what is proven to be the most effective currently and leveraging technology accordingly? And then we also have to think about safety. Are we keeping people safe? Are we preventing injuries, accidental or otherwise, from occurring within our health systems? Now, one of the things that came out of a lot of those IOM reports is the 6 domains of healthcare quality. And so when I say something is quality care, I'm saying that it's safe, that it's effective, it gets us to the outcome we expect. It's patient-centered, it's built around what the patient needs, not just the system and the facility and the organization and the staff. Although I love the idea of what I call patient-centered, staff-supportive processes. That definition for me used to start out as patient-centered, staff-supported, that term. The idea that staff were centering their work around patients. But then it shifted for me a little bit to staff supportive, meaning we as management come in and support our staff, we empower them, we are caring for them so that they care for our patients. It's this continuum of care, it's this flow of value straight to the patient where everyone feels like they're part of the process. Of course, it also needs to be timely, right? If you're waiting hours, right, that's going to shift not only your perception, but your outcomes, right? As your body changes and, physiologically things happen as you're waiting for care. Efficiency, right? The ability to do a lot with a little, of course, is central to implementing quality services. And then equity. If it's quality for one, but not for all, if it's quality for the patient with the right insurance or the right access or within 10 miles of our hospital, that's not quality. Quality is about having good outcomes for everybody. And so these are our six domains. When we think about evaluating our outcomes, we often talk about these structure process outcome goals, right? The idea that we have the right staff in place at our clinics, the idea that they're giving that needed vaccine, the idea that then we reduce the likelihood of a patient or a child having measles. It's that continuum. We have to have the staffing and the resources, supply chain management in place. Hence, all the work that we do as health services administrators in order to get to that right outcome. Now, some outcomes are pretty traceable like this. We can see how this could make sense. Other outcomes sometimes aren't, right? Sometimes it's 20 things that have to be in place, folks that have to be executing perfectly to get to an outcome. It's not as close to a one-to-one relationship. And so it's important that we're always doing our jobs in a thoughtful, meaningful way in alignment with policies and procedures, updating those policies and procedures, because it's not always, oh, I do my job, this happens. Sometimes you do your job all day, every day. You make little improvements each week, right? We're gradually, improving based on things that we see in the literature and evidence basis and good clinical practice. And then years later, we see the benefit in population health. Now, there's a lot of different terms, so I'm going to leave this up for a moment that we use when we're talking about quality improvement. And I'll use a lot of these terms. You'll notice that certain terms get associated with different methodologies. For this particular course of modules that you see here, I am focusing on a performance improvement lens, the idea that we're continuously reviewing and evaluating what we're doing and doing better, to implement quality improvement, continuous process improvement, with tools from the Six Sigma and the Lean methodologies. These are two different methodologies that we're going to talk about that are very important. TQM, or Total Quality Management, has been a methodology that's been very well funded and highlighted in the US healthcare system. We'll talk about that briefly as well, but it's really more of a high level overview of quality improvement approaches. Of course, we always want to be effective. We need to use our change management skills. So these are all terms that you're going to see me use quite a bit. Again, total quality management is more of this high level approach where we are focusing on the customer. We are constantly evaluating what we're doing for improvement, and we're implementing teamwork-based strategies. So more than one person's accountable, a lot of team-based work. Those are the fundamental principles of TQM. But again, for this course, we're going to be focusing on very specific tools related to Lean, Six Sigma, and quality improvement. When we think about the continuum of quality, all that we need to do, we often, and a lot of my examples center in organizations, we often think about these examples from a perspective of an organization being less or more mature. And when I say less or more mature, I'm referring to data processes. I'm referring to automation. I've worked in very small organizations that didn't have even an electronic health record back in the day, less data mature, to organizations that have many automated processes, but maybe have less oversight. So all sorts of organizations have all sorts of challenges and different leveraging of technology. But this particular graphic here is meant to symbolize what it means to go from being less mature, less advanced in our utilization of technology or metrics or quality improvement processes, all the way up to being the most mature. So this grid has different examples and what it means to be more mature when it relates to things like quality priorities, how we choose and set what we focus on, how transparent we are, our methods, our measures, things that we measure, and how we leverage information technology in that space. Is IT integrated into all of our audits? Are some of them automated where we don't even have to do an audit? It automatically checks for compliance. Versus, do we have AI helping us make recommendations? All the way down to, is there no integration, right? So each one of these domains has levels of maturity, and you'll find organizations may be in different places. And some organizations may be coming up to speed pretty quick with the advent and the institution of AI. Other organizations may really be in a survival mode right now with changes in payment systems and everything that we're going through with the changing insurance landscape. Speaking of change, it's really, really important that we realize how much health plans and health insurance drive how we're compensated for care, how we coordinate care, and how care is delivered, whether we like it or not. So this particular example is a Florida health plan, has an oncologist who is demanding payment from the patient um, for the portion of the chemotherapy not covered by Medicare. And this is called the copayment. Um, Now, some copayments are several $1,000s. And if you know anything about Medicare, quite often Medicare wants the patient to pay their portion while Medicare's paying their portion, right? And it could be a copayment, it could be coinsurance, depending on the procedure, what we're talking about, or a different health plan. But either way, the expectation that the patient will pay and be equally yoked, they'll have the same amount of moral hazard, if you will, of decreasing the likelihood of adverse selection, that patient's engaged, they're paying for their part of their care. And there's a lot of concerns with this method, but it is standard practice with most Medicare health plans and federal policy that patients should pay their share of cost if they're expecting the government to pay a portion. And as a two-time, hopefully at this point, cancer survivor, I have some very unique opinions about this and about the cost, some lived experience in that space, having taken care of family members who've passed and dealt with this very specifically. It is very unfortunate that we live in a world in which insurance drives so much of that. I know with my last cancer experience, I had to have more than one surgery because that's the way the insurance company wanted to pay for and scaffold that. More than one set of recovery, if you will. Anyways, uh, when we think about what's driving change, change is not just something we have to do in order to keep up. It's something we have to do to stay in business. So we're not even talking about keeping up or growing anymore. We're talking about staying in business. And so this represents something that you may read and say, ooh, is this just? Is this fair? A lot of how our health system functions, right, is different organizations trying to stay in business. And so we're going to talk quite a bit about that in this course and what it means to try to shift to a patient-centered model while still implementing change that allows us to continue to stay financially viable. Now, I've got a couple graphics here, some of which are a few years old because I'm pulling them from different resources that are telling different stories. This is an infant mortality rate graphic from a text that I love to utilize, that I utilize quite a bit. It's Dr. Leiter's performance improvement text. And this is from 2004, over 20 years ago. And you'll notice that the United States is doing terribly. This is a graphic that I circulated early in my career that I used in a lot of my lectures, and I talked about this. And my question for you is, have things gotten better in the last 20 years? What do you think? What we've seen, in fact, is a growing disparity. Mothers in Alabama and Georgia and Mississippi struggling. We see that infant mortality being markedly high in certain regions and certain demographics, right? We see the continued suffering of certain populations. And so this discussion has been going on for a really long time. This is data circulated, again, 2004 data circulated in 2008 in that CDC document. This moves us forward a little bit, but not quite to current state. We're going to see some current state data later on in some future lectures. This is 2017. So when I think going back about 10 years, in the late teens and early 2020s, we had a huge a federal effort around funding for MCH, around maternal child health funding. And you can see here the United States is still the highest when we look at neonatal and post-neonatal mortality in this comparison to other OECD nations. So other, what we would say first world maybe, or, industrialized nations with resources. You'll also notice that looking at this page, all of these other nations have some form of universal health care. So not a lot of strides being made. If we go back to that original resource, like I said, I like to use Dr. Leiter's Basics of Performance Improvement resources. This is a graphic from that resource that shows healthcare costs. Now, again, this graphic now is about 20 years old. We're at the top. I know you know that that trend has continued, right? I have a healthcare finance textbook that I've been privileged to be co-author on, where I have a lot of analysis of that trend, and we see that as we've paired off that not only has that trend continued to go up, but spending across different sectors. We have the highest in billing and insurance related costs, but we also see accelerated spending in what I would say is the wrong areas. And that's what this graphic is meant to show us. This is the United States and what we were spending money on in 2018. At this time where a lot of critical reflection is going on, we're trying to change the health system. And again, we can reflect on this because there was so much federal funding going into this analysis and statewide funding in different states. At the time, I was in California. Now I'm in the Mid-South. Um, what we see here is very little funding in the long-term care space compared to the comparable country average, right? Less than half of the dollars spent, but a very small percentage when you compare. So the comparable country average in 2018 was spending about 5,500 on care per person per capita. We were spending almost double that, but less than half of the exact dollar amount. So 25%, if you will, a quarter of the ratio on long-term care. Instead, we're spending that on inpatient and outpatient. We're spending that on administration. And I would argue that that administrative component is grossly underrepresented when you think about everything else. You'll also notice our amount of money that's preventive is higher, but not effectively. Not higher as a total percentage, but higher in general. And you'll notice that we're not getting those outcomes that we would expect. Now, this is another graphic, again, slightly dated, but I'm telling you a story here and what I want you to see. Coming from my perspective as a professional who's worked in health services administration for over 20 years, has talked about this data for a long time, has seen the changes over time, and has seen our situation arguably get worse year over year, seeing outcomes slip, seeing financial costs go up, seeing patients suffer in my life, in my students, in our health systems. Uh, this is a tough story. So this is showing that comparison in what we're spending administrative costs versus long-term care. That story I was telling you earlier. So we are spending the most in administrative costs, not the least in long-term care, because again, this is dollars spent, not a percentage, right? South Korea spends a lot less than we do on healthcare and a larger percentage on long-term care, but fewer dollar equivalents. Now, this graphic here runs us through 2020. So this is right before COVID. And this is health consumption expenditures as a percentage of GDP. You'll notice I've got another graphic on the side here that shows, and this is kind of a graphic I like to generate occasionally from our World in Data to show how we continue to pay more and not get an equivalent jump in life expectancy. So that's what's over here, where you can see we're paying more. Life expectancy isn't going up as we see in other countries. So we continue to pay more. We spent more during COVID. We spent a lot in the population public health space, of course, as did a lot of nations, but we also spent a lot in trying to rewire our health system and really push money into inpatient care delivery and offer more services. Now, this again, the next few slides are graphics going back to the lighter text. So these are dated slightly, but telling a story. This is the percentage of adults ages 19 to 64 with any medical debt. Now we know this has gone up. When we talk later on about controlling for problems and looking at data over time, I'll show you some data of where we're currently at with medical debt. But to say that half of the country is struggling with this is not an understatement anymore. So seeing that every year more and more folks have to deal with some sort of medical debt. As someone that has worked in health services in the financial sector, I will tell you that every time I face an illness, and I've had several, I have a chronic disease, but I've had several situations. I've had, multiple cancers where I've had to deal with this. It is always a setting aside of considerable funds, even though I always have the best in class local insurance and resources. And so that really begs the question of what situation would I be in if I was diagnosed and didn't have any of those resources? And so we'll talk through some of that from a microethics perspective, but also a macroethics perspective of what do we do at a systems level to prevent that. And you'll notice right now we're not really talking about quality in a system. We're talking about health status of a population, and this is raising how important it is that we address these things. This particular slide looks at some differences across health outcomes and access to across uh, demographic groups looking at access to primary care. If you are Latino Hispanic, if you are Black, you tend to have less access. We know this. The data shows us this. This is specifically from the MEPS from 2011, but year over year, we see this data. And this was put together and packaged again as part of an effort to highlight this need. And it was paired with this graph here, which shows the percentage of primary care physicians who are satisfied or very satisfied with their medical practice. So physicians in the United States are towards the lower level of satisfaction, but higher than a few other countries in this particular survey. Interesting, right? But what we're seeing is that providers are not satisfied, patients are not receiving the care they need, they don't have the access in general. So this has been a story. We can update the data year over year. We can look at it again and again, but this is the story we've been telling for an extended period of time. I personally have been teaching about 15 years in health services, having the same discussion about how do we move the needle on these population health indicators. And so I want to share that to start with because I don't want you to feel overwhelmed by it, but I want you to see the challenge that we're facing and be prepared to think about how your work can deliver value to patients every day, to families, even if you're working in a finance department or a quality improvement department or health IT or with a vendor on a project. How do we as a whole translate value? And so these are our stakeholders. We've got payers, insurance companies, employers, federal, state government, all part of this, all trying to change this picture. Then we've got work that we're doing to align behaviors with incentives. So when we think about how do we deliver high quality care, but also incentivize a patient to eat well and not need that cardiac procedure? How do we create the right incentives in public health, in health behavior, and still create and prioritize life-saving treatments? Realizing our number one goal is really always patient safety. Earlier, I alluded to this report that is now, many, many years, almost 30 years old, to Err is Human, which showed us how many individuals are passing away in inpatient facilities, preventable deaths due to medical errors in the hospital, and in long-term care, spending so much money, not just addressing those errors. Facilities are losing money for uncompensated care for those errors. Patients are physically suffering. How do we even begin to tackle what has become not accepted, but normal? It is everywhere. We have patients who are hurting and being injured every day in our health system. And this is something that was highlighted again almost 30 years ago and something that we have yet to fully rectify. Now, we've got some initiatives in place to address that. After that report in 1999, in 2002, the Joint Commission came out with something called the National Patient Safety Goals. And these are things like a do not use list of abbreviations so we don't make as many mistakes. We've got infection control measures that are put in place that are new to prevent hospital and now what we call healthcare associated conditions. We used to call them hospital acquired infections. We've got programs encouraging patients and staff to speak up And we've got universal protocol programs that work to ensure that we're checking everything before and after surgery. We're preventing things like wrong site, wrong procedure, wrong person surgeries. We're really being diligent in how we conduct our care. Now, realizing that patient safety is paramount, we have a lot of resources. We have the Federal Agency for Healthcare Research and Quality. We've got online journals and funded medical research and clinical quality research. We've got patient safety networks and educational events. And we've got a lot of these other programs and tips and best practices like Team Steps that we'll talk about later. That's a team-based quality improvement initiative. We also have these really great methodologies we're going to use, like Lean Six Sigma. These tools like conducting failure mode effect analyses and SIPOCs and House of Quality diagrams, these little tools we can use as we analyze and improve processes. And so we'll be learning about that in this class together. I do want to circle back to that idea of accountability. Our number one job is quality. And so there are a lot of forces in place in the marketplace. We've got health grades that grades institutions. We've got the Joint Commission coming in and auditing facilities every few years. We've got the Center for Medicare and Medicaid Services putting standards down and updating those conditions of participation, is what we call those. We've got these folks in place. But we also have to realize at the heart of it all, these are regulatory agencies that are meant to disseminate best practices, come in and check at a very high level that what we're doing is appropriate, high quality, and ethical. But at the end of the day, we have to be responsible, individual by individual, and accountable. We can't walk away. We can't say it'll be fine. The next nurse will take care of that. The next staff member will look at that report. We have to start infusing a spirit of accountability into everything we do. It's you and me. And if every provider, every physician, every nurse, every health services administrator, every care manager, every therapist, every PTOT speech therapist, if everyone was just as conscientious as you are and just as accountable as you are every day, would our system be successful? And I want you to really think about that because we're now coming across an accountability crisis, I think, in our health system where things kind of just keep slipping year after year. A lot of the measures keep getting worse. Some of the measures stay because we monitor them closely and we have administrative controls in place and we have good clinical folks. And this is not an accusation, it's a call to action to feel motivated that each of us wants to be a leader in doing anything we can to make our patients safer. All right. Well, thank you so much for listening to this first overview, what we call Module 1, an overview of healthcare quality. In my future recordings, I'll be covering over different steps of quality improvement through the Lean Six Sigma. So we'll be talking about defining a problem, measuring it, analyzing it, improving it, and controlling, as well as a little bit about the future of the US healthcare system and different metrics that we're measuring, looking at accountable care organizations and integrated delivery systems. So thank you for your time today. I hope that this was helpful in giving us a baseline, and I look forward to sharing more with you all in the future. Thanks, everybody.